the AOT implementation TAC team. I also had oversight of a large AOT program in Hamilton County, Ohio. That's in Cincinnati. So that's kind of my background, and welcome everyone. We're so glad you're here this afternoon.
And Brooke.
Hey everyone, my name is Brooke Gentry. I am the AOT implementation manager on the team. And so my role's really focused on managing our educational offerings. And I just wanted to say shout out to all of you and Gold Star. I was worried we would have a really small group because of the holidays. And this is actually a bigger small group than I expected. So I appreciate all of you coming today and am excited to get into the discussion.
All right, thank you. The team is missing two folks here, Shanti Silver, who oversees our research component of our implementation team, and Jared Wyma Bradley. They're not in Washington, but they are at a stakeholder meeting, a virtual stakeholder meeting in Washington State. So trying to get things off the ground there. All right, so let's find out who you are. And I am going to most likely, unless your name is very simple, mispronounce. So please correct me and I'll try to get it right next time. Laura Cracian? Cracian?
Laura Crichon. I'm the co-chair to the Policy Action Committee meeting to the National Shattering Silence Coalition, and I am actively promoting AOT nationwide and trying to go face to face with its opposition and convince every civil rights advocacy group why we need AOT in all 50 states so that it can become unified and have best practices as a guide. And we at National Shattering are trying to put a light on all the successful cases of AOT so that we can help better sell it in legislation and in the community and bring more awareness of its existence. Because as you know, in Maine, we have an AOT. The PTP program is not even being utilized because of its non-popularity. So I guess in essence, I'm trying to do a branding of coercive treatment and using AOT, information as possible. So I'm here to attend and get as much information as I can about why we need to show how it's working.
Excellent. All right. Well, welcome. Kiri Crane.
I am the director of the Johnson County, Iowa AOT program. We are about 2.5 years in. I know, hard to believe. Yeah, yep. And I am just here to see what resources I can find amongst all of you who have been doing it a little bit longer than I have.
Devin Roots.
Hi, can y'all hear me?
Yep.
Okay. I am a RM program coordinator for South Central Louisiana Human Services Authority, but my role for AOT will be the project evaluator, monitor, and I joined today because I am new and trying to learn as much as I can before we start. We're just received our grant.
Excellent. Welcome. Brian Cook. That I got right.
That name falls in one of the simple name categories, right?
Exactly.
Thank you for hosting this. It's good to be here. Yeah, I'm definitely on the spectrum of experienced to not very experienced, very much on the not very experienced side. Well, I've been working in community mental health as a crisis counselor for my entire career for 20 years now. We're just now looking at programs like AOT, or so my location is a very rural 6 counties in Kansas. So AOT is pretty new to us, but particularly new to our center. We don't have a grant to do AOT. It's something that we're trying to do just bottom up, and some judges will listen to us a little bit and might, say, okay, that sounds interesting. Other judges have not agreed to meet with us yet. But so I'm here because I really have a lot of interest. I think there is a segment of the population, I'm going to mispronounce the word, but the anosognosia clients where there really is a lot of severe challenges, and there's a lot of interactions with law enforcement and in and out of the hospital that it was just sort of repeating. We're stuck in a cycle. We'd really like to try to engage and reach those folks too. And this seems like a way to do that in a humanizing way. So I guess I'm getting wordy. I'm here to learn, here to listen to you guys.
Well, I think that while we are AOT practitioners, this call should be applicable to any practitioner, frankly, because we want to talk about trauma and its impact, not on our clients, which there is a ton of impact there, but also on our staff. So, Erin Weatherden.
Hi, I am an AOT case manager in Flint, Michigan. I work strictly with either AOT or AOT NGRI clients combined. And I'm looking forward to learning more because I absolutely love AOT and what it allows me to help my clients do.
I am so glad you're here. We haven't had much contact with Flint in a while, but I've been reaching out to Jenny.
Jenny Kimmel is no longer our supervisor. She has moved over to Eastern Michigan.
Yeah, I'm aware of that, but hopefully she'll still be supporting you in her new role.
I hope so. I can send you Ashley's number. She's our new AOT supervisor.
Oh, excellent. Great. I'd love to have it.
All right. I'll put it in the chat.
Thank you. Jacob Grillo.
Close, it's Grillo. We pronounce the L's. Yeah.
Oh.
No, no problem. Yeah. So Jacob Grillo, I'm Washington State, Snohomish County. We're in the process of implementing AOT here. I'm a PA by profession. I'm a business owner too of our behavioral health agency, and so we're getting pretty close to implementation. And yeah, I'm really just interested in learning how other states are navigating kind of some more of the sensitive issues and kind of how their legal system deals with things compared to our legal system in regard to like specifics regarding like the orders that judges give. Do other states, do the judges specify things like, a part of your conditions is to get your monthly injection that's recommended, or do they want to not name medications in their orders? Those are kind of some of the topics I'm curious about.
All right. So we've got mostly new folks, but that's good. That's good. So I'm going to answer your question, Jacob, just because I can do that quickly. And that is, we recommend that judges be fairly vague when it comes to required treatment in court orders. And so what we recommend is that they outline specific services like medication management or case management or counseling. Because if something goes in the court order, to change it, you have to go back and get a new court order. That's way too cumbersome for a treatment provider who needs to make changes on the fly.
Mm-hmm.
So
That makes sense.
That's what we recommend. And I think it's important for all to understand that AOT is not court-ordered medication. So you cannot administer injections to someone who is involuntary. So we don't do forced medications in the community.
Right. Yeah. And that's anywhere, right? I mean, because honestly, to me, it feels like a gap. I can think of several patients who are on that repeated cycle because they won't do an injectable. And so they're continually being hospitalized or continue being incarcerated because they can't adhere to medications orally. Now I'm not talking about forced injection, emergency forced injections or anything, but I'm just curious. Like, I think that's an important conversation that I think I need clarity on. It feels like a gap because I have patients like that who continually, repetitiously have relapse of symptoms. Yeah, but they're not willing to do injectable voluntarily.
Curious, Erin, do you ever run into that or Carrie, either of you, because you actually are in the thick of it?
Sorry,
Go ahead.
Go ahead. We have had clients that were on long-term injectables, and even with us being involved, they were still being transferred to inpatient every month because they're not wanting to take their injection. So we more or less just had I had a very straightforward conversation because at one point, one of the participants had identified that it's very embarrassing to be hauled into the hospital by the police.
Yeah.
So I just had a very straightforward conversation with him and said, you have two options. You can get in the car with us every month and we can take you to the hospital. You can get your injection. We'll buy you food before or after, and we'll take you back home and we'll see you again next month. Or you can go through the embarrassment, get in the big shiny car with the bright shiny handcuffs, and the police can take you.
Yeah.
That individual started going with us to the hospital to get their injection.
Yeah. Yeah.
So we work really closely with our hospital, which literally used to be across the street from us. And so when we have a client that's non-compliant with their long-acting injectable, we work with with the sergeant that's attached to our AOT department. And we will do an AOT violation, pick them up, take them to hospital, get them their injection in the ED, and then we take them home. Or the hospital sends them home. And when possible, their case manager will go with them to the hospital so that they don't get put inpatient by accident, because most times they don't need inpatient, they just need their damn injectable. So we have worked with the social workers at the ED to just give them their injection if that's what we're asking for.
I would like to know more about that process with you guys. And what state are you in?
I'm in Michigan.
You're in Michigan. Okay. Yeah, we had a conversation with our judge, and he did not take our conversation very well. With we weren't implying we hold everyone down and give them injections, but we were trying to have that dialogue with the judge, and he didn't want anything to do with ordering or anything like that with an injectable medication. But it sounds like you have an avenue in which you're able to use or involve police in order to get the recommended injectable.
Yeah, 2 police officers, 2 police sergeants that are attached to our department, which is kind of funny because we only have 4 case managers and 2 police officers. But Judge Barkey is our probate judge, and she is absolutely fantastic, and she's there for what the clients need.
Mm-hmm.
And that's the way we present it, is if the client gets this, then we don't have to do X, Y, and Z. And so it's the least restrictive possible. And using the words least restrictive seems to, because and I would imagine it's the same nationwide, but I could be wrong. We're always supposed to do the least restrictive measures possible. So getting their injection means they don't go to hospital, which means it's far less restrictive.
Yeah.
So that would help. I know, like today I had a discussion. We have a client that is not currently on a long-acting injection, but his court order does say that if prescribed, he is required to take it. He does not want to. So I reached out to Sergeant Howard today and said, okay, we're going to be bringing him in for this injection. He will refuse it. And at that point, you and I will take him to Hurley. I will talk to Zach, the Hurley ED social worker, prior to that. And that way they have it ready to go. We're going to walk him in, get him his shot. If he loses the shit, he can go to behavioral health unit upstairs. But if he can just decide that getting the injection is fine, then he can go home.
Wow. Yeah.
But we also spend a lot of time, and Jenny Kimmel was absolutely fantastic about having meetings regularly with the local hospitals about legally what is their responsibility to a court order, and like spelling out, this is the part of the mental health code that covers AOTs. No, it is not the same as the rest of the mental health code. Yes, we can force someone to take their injection if they are court ordered, because there's a whole separate set of the mental health code for AOTs.
So I think it's important to note that everybody's state statute is different. Some have that. Some have court-ordered involuntary medication in the statute.
Yeah.
Some do not, and my guess is Washington probably does not. So that's number one. Number two is, this is not the first intervention that you try in AOT. Right. This is when someone is decompensating, and if they don't get their injection, they will end up in the hospital. So there's a whole lot of outreach that needs to happen first before you call the cops. And not to put Sarah on the spot, but I know you've looked at the statute. I know you haven't studied it, but did you note anything about involuntary pickups
in Washington State?
Yes.
I would have to say I didn't get that far. I got stuck on the piece that I was studying, so I'm sorry. I would certainly do that and follow up with you.
I will say that even for those states that don't have involuntary medication in the statute, you can always, again, if someone is decompensating, you can always ask for a pickup order for an evaluation. The sole, it's not go get them and we'll give them their shot. It's go get them, bring them to whatever crisis center or emergency room is in your jurisdiction. They will be evaluated, and a lot of jurisdictions will say, well, you can go ahead and get this shot, or we're going to have to put you inpatient. That's pretty common. And Brian, do you have experience with that? I know you don't have AOT yet, but being in the crisis center.
Yeah. Sometimes we do have emergency rooms that use emergency protocols if someone's really escalated, but that really doesn't match our conversation right now, which is more of like, I think if I understand right, we're sort of predicting that history has shown we're going to go really downhill really fast if we don't get back on track with the medicine. And so my experience is very limited, but we did have a court hearing recently where the ACT team that the person really knew and had a relationship with was there. And I was sort of there as I don't want to use the phrase the bad guy, but the person that asked the judge so that the ACT team could sort of stay out of that, asked the judge something like, Your Honor, we're sort of noticing that we're not where we need to be. We were kind of hoping that you would spend some time talking to the individual about the importance of these things and maybe what happens if we can't get back on track. I was sort of fudging my words up pretty badly, and the county attorney jumped in and said, Your Honor, we need an admonishment, I think was what he called it. So the judge then took that and ran with it and had sort of a firm, transparent conversation with the person. Do you understand what will happen if you don't agree to start taking your medicine? Do you understand what will happen? Do you understand what the court can do if this or that? And it was a pretty rough conversation, but afterwards, the individual came out of the hearing, and the first thing that I heard them say to his team was, well, I guess I better start taking my medicine again. Anyway, I don't have as much experience as the rest of you, but that was a recent one.
Yeah, the status conferences are fantastic for that, aren't they? We have monthly
Agreed.
status with our conference or with our judge to have that black robe effect that as long as you're a decent rule follower, you'll follow. If you're not a rule follower, you don't care.
That's true.
And I think like what you were saying, or I think you mentioned anosognosia, Brian, that, what Amy was saying is you have this kind of your tools, your bag of tricks that you're going to try to use to engage your participant before it gets to that point. But it's really about helping them, even if they are not going to be able to gain insight that they do have a mental illness, helping them make that connection between better quality of life and adhering to medication, adhering to their treatment plan, that kind of thing, which is, easier to say than to do, but that as you're kind of working out what does your participant want, what are their goals, and if you can connect that to adhering to treatment, then you might be able to get further before things kind of get to the point where they need to be picked up. But I wanted to say that Erin, one thing I heard a lot when you were talking was you were mentioning multiple collaborators. And I think that's so important for the new folks on the call to think about, that those efforts are requiring different players. I think Aaron, you mentioned the hospital, you mentioned the sheriff's deputy, you may have mentioned others, and that in order to kind of intervene when your participant needs that intervention, you are collaborating in real time. And so for those of you that are new, it's really important to establish those relationships and kind of plan of communication at the outset.
Yeah, I would definitely second that. I'm running into a situation right now where we have a participant that is very transient and moves between Iowa City and Cedar Rapids, and we're about 35 minutes apart, interstate drive time. And he is past due for his injection. I found out he had been getting into some trouble with law enforcement in Cedar Rapids. So I reached out to Cedar Rapids and said, hey, it's my understanding you have this person in jail right now. They need their injection. If I can get you the injection, can you give it to him before he is released? While at the same time sending the same information to the hospital in Iowa City saying, hey, this person's late for their injection. If you happen to see them and you haven't heard otherwise from me, please give them the injection before you discharge. And then once the injection has happened, I then email everyone and say, we got him, talk to you next month. But at the same time, kind of back to the original statement that I made about just having that very frank conversation. A lot of times our participants have been in the system for so long and they're used to people telling them what to do and never explaining why they're being told that. If you're able to just have that conversation of, here's why we're asking you to do this, here's what will happen if you don't follow through, generally they will do what you're asking them to do voluntarily because they understand, okay, you are actually giving me options. And they also know that no matter what they choose, even if they choose not to follow through with the medication, that you're still going to be there to provide whatever support they need during that time. I had just did a presentation a couple of weeks ago, and I said, as my role as the monitor, I felt like it was number one goal is to treat our participants like humans that have options. So that's kind of how we go about it in our program.
I think that is so important, recognizing that even though there is a court order, people still make choices and they have the right to make those choices. They're not always the choices we would make, but our role is not to tell them what they have to do, but to help them see why it's in their best interest to do what they should do.
That's really helpful. Thank you, everybody. Can I ask another question, or is there an agenda?
We always plan a topic just in case people don't have questions. So ask away.
Ask away. Okay. Is anybody using any like contingency management in their programs?
That question is coming up more and more. And I am not aware of any at this point that are using contingency management. And I'll be honest, I haven't looked into the research on it. but my thought is that if this is going to be a limited state, the court order is not going to last forever, that we really need to build internal motivation, which is why when we talk about the court order, we always talk about adherence instead of compliance. In court, attorneys, judges, you'll hear compliance with the court order. Compliance, compliance, compliance. Compliance is an external motivation. You comply with something because something negative will happen to you. Somebody will do something negative if you don't. Adherence is understanding that I do this because it makes my life better. And that's our goal with AOT. And Jacob, could you explain what you mean by contingency management? I think that's something that you hear a lot in the SUD arena and not so much in treatment for SMI.
Yeah. So contingency management has been shown to be really effective, probably the most effective thing for meth use or methamphetamine use. Just because there's no like medication options at all for it. There's very limited data on some things. But, so contingency management, some people call it incentive, but other people don't like that word. But it's some sort of positive reinforcement for in our case, adhering to their treatment plan per se. So you could have some sort of point system where they reach a certain amount of points and they can get something out of a prize bin, or it's something like that, to where it's just that positive reward. As probably is what I would call it best. Does that sound okay as a definition, a loose definition?
Yeah. And I think I was talking to my friend last week who is potty training her 2-year-old, and she is using contingency management.
Yep.
And, every time he sits on the potty, he doesn't have to do anything. He gets a sticker. And then after he gets 10 stickers, he gets a truck. So that's contingency management.
Yeah.
And Amy, I was going to add, just from my experience, just on a small scale, not really contingency management, but there have been the use of like gift cards when somebody who has not shown up for appointments starts showing up, or taking somebody out to McDonald's. It's more to establish relationship than to really motivate, but it is actually used to motivate, but that's on a small scale.
Yeah, I am a strong believer in the hamburger intervention. If you want to if you want to have a real conversation, do it outside the office. Take someone for coffee or hamburger or whatever. Folks, I think that in my experience that the positive reinforcement that our participants get from the treatment team and the judge, they go a long way. I mean, I don't, like I said, I'm not aware of any program that uses formal contingency management. I will say, Brian, that Judge Winnell has gift cards that he offers every so often, but they're $5, and it's not like you get one if you take your medication.
I will say, in our Iowa program, we do have a portion of money for incentives. And we, in the beginning, since it was a little bit of a struggle to get participants to want to come to our check-ins, we had, always had snacks and things like that as kind of our incentive. And it takes one to spoil the fun for everyone else. So we had some participants that would kind of take a little more advantage than others. So we stopped doing that, but now we do, for instance, since this is December and we want to make sure that everyone, is treated the same. I was allowed to buy things like I bought blankets, socks, laundry detergent, hygiene items. And then as everyone is coming in this month, we're allowing them to pick from those items, and they can take one or two things home with them. But also throwing in, everyone can have a calendar for next year and a daily planner. So I consider it an incentive. They just see it as, hey, it's Christmas, you're giving me stuff. But it lit up everyone's face yesterday when they realized that, we appreciated them attending and they got to take something home with them. We also do utilize we have some individuals that we know their injections will upset their stomachs, and that's why they don't like going. So we also utilize that money to get them food before they go so that they're more willing to go. But with that, I think it's, kind of Pavlov's dog. Now they know every time they get an injection, they're going to get food. So that's a little bit of an incentive as well.
Erin, do you all use any incentives?
I have a few clients that I happily bribe to do what I need them to do, but it comes out of my pocket. Our department's too small to have its own budget, but I have one client, she refused to be seen in medication clinic except for through telehealth, and we really needed her to come in, and it had been 9 months. So I was like, if you come in, I'll give you a $10 gift card to Dollar General. So she's like, okay. And she has come in every single month for her injection, every single month for her medication review. Like, she's on 3-month medication reviews now because she started coming in regularly.
So is it costing you $10 every time she comes in?
It does, but she comes in, so I don't have to violate her AOT anymore. Judge Barkey doesn't have to see her anymore as much, so it's worth it.
And just an idea, we did not have any funding for our AOT program when I was a case manager. But what we did have is our local NAMI provided gift cards for shoes, gift cards for movies. So if you have a local NAMI, partnering with them is helpful on a number of levels, but in terms of...
We do have a fairly active one in Flint, so I'll reach out to them.
And just, I'm paying $10. No, just have them... We have this group of people, and if you are interested in buying gift cards, fabulous. Yeah.
And I'd put something in the chat too.
Oh, yes. IMR is a great EBP to implement. And that brings up one more thing that I think is a tremendous engagement technique is the use of peers. And I know Carrie relies on her peer to do outreach. So I want to hear if anybody else has peer support available for their programs.
We will when we get started. We have, yeah, that's part of our kind of our program is, when we start, we're going to have a nurse case manager and 3 peers, that kind of do the bulk of the heavy lifting, and then that's the core of the team, and then we'll have the therapists and med management people as well.
Yeah, I can't say enough good things about peers. Just in my experience doing homeless outreach, my peer support staff could get much farther in engaging someone than I could at the beginning.
Amy, we have 4 full-time peer support specialists with our agency, so we're very lucky. And yes, I do see that they reach out and they can have a good rapport that is very helpful. Yes.
And I know you're not implementing yet, but is your intention to use peer support to augment the services that you provide?
I'm pretty sure, absolutely. Because we'll be using our agency, and that's one of our services. So, yes.
I don't want to take us backwards, but I really quickly wanted to highlight, Carrie, what you were saying about getting folks food before their injection. I think that's a really amazing thing that y'all are doing. And it made me think about how, when you have participants and they don't want to adhere to treatment, dig a little deeper. Why is that? If they don't feel, if their stomach is upset, I think that's kind of a natural reaction to not want to. And so, as you're trying to get someone to adhere, really asking them why it is that they are not wanting to do something, and then a creative solution like that is excellent. Because not only are you coming up with a creative solution, but your participants are hearing that you're actively problem solving for them and you're taking their concerns seriously. So kudos.
Yeah, that's so important. So important. And it really is, listening to the participant or your clients. That is the hallmark of person-centered care, which is person-centered care is so important to AOT and increasing adherence. And unfortunately, I think a lot of times it's given lip service. Of course, we do person-centered care, but then we go back to doing what we always did, which was not. So I'm not saying you do, but systems.
And I think part of that is client-centered care isn't convenient. And we're a society of convenience.
Oh, we are. That's absolutely true. I also think that that EHRs have electronic health records have impeded our ability to really focus on client-centered care. Anybody have any other topics that they want to talk about or address, have questions about?
I do.
Excellent.
What I want to know is how many of you are collecting your success stories, because we need more of the attention on how AOT works and people who are in the program willing to speak out publicly in favor of how their treatment was. We were hearing from one judge that the arrival is 0% non-approval rating, and then upon dismissed, it's 90% approval rating. But we're not hearing the stories enough to convince the rest of the country. So if anybody can help me gather the stories, that's what I need. I guess that's more of a request than a question.
I may be able to help you out with that, Laura. Treatment Advocacy Center has been working on developing an AOT Speakers Bureau, which is just kind of a fancy word for AOT graduates who are willing to share about their experience in the program. And so we have like 5 members right now, and are growing it. But if you put, actually, I have your email because I have the registration. I can reach out and connect you with I don't know what you have in mind.
We have in mind a monthly call out to one success story per month to feature. And it's going to be sent out to many people. Plus, we could put it online on our website to just collect on, like on the Cures Foundation website, they have all the success stories of recovery listed on their page. We want to have a page dedicated to AOT specifically, those success stories, and that they can be modeled and be looked at as a example or something to achieve or strive for the country at large. Because a lot of the opposition is about saying they are only showing Eric Smith, for instance, or Bradley Newman-Tarr. There's only 2 examples of great AOT successes. So it's a thing we actually need to spread AOT awareness more.
Got it.
Now,
Yeah.
Something that we could like refer a client to, because I'll be honest, I don't have time to sit and collect somebody's story, but I do have a lot of successes from clients that, like, I have one lady, she went from her children absolutely refusing to talk to her when she finished her AOT. She was babysitting her grandbabies again. I mean, that was amazing.
You don't have to do the work. You just get me the contact information and I will get all their, I can have editors write it. We'd have people put it into words for you, but no, that's not what we need. We need just the names.
Okay. Could you put your contact info in chat and then I can coordinate? Because I have several that I'd be happy to share.
Right. Okay, great. That's what I'm asking. Yeah, because this is something, if we even had it in a more national news way, we can, if I know some people don't like attention and they want anonymity, we don't actually even need their real names when we publish it, but just a story that we can keep going and collecting.
And Erin, feel free to send any graduates my way too if you think they're interested in joining the Speakers Bureau.
Okay.
And Laura, I can also send you or refer you to someone. The only thing I'll say is we really want them to, gain more from the opportunity than just the advocacy aspect. So we are paying them for their time. So just keep in mind that if you do go with any graduates from the Speakers Bureau, and I would also recommend just for any graduates you work with, paying them for their time testifying, because I know that that's always really appreciated, and it doesn't have to be, $1 million, but I think it's a good practice.
Well, we are 100% volunteer organization. None of our employees are paid, so I don't know how we do that, but we could also market them to get better jobs as peer counselors after they graduate. A lot of people graduate from AOT, go on and work as peers. So this could be part of their bio. I don't know, but we'll think about that as well.
Well, Laura, I was going to add that, often numbers speak louder even than the stories, and a lot of AOT programs collect data. TAC has data to show the effectiveness of AOT, so that may be something
Doesn't
else.
seem to be piercing our civil rights advocates. They need
Oh,
stories.
okay, so you're already using the numbers in the research.
Yep.
And I would imagine Aaron has great data as well, since they were. Well, you have data. I know that because you were a grantee up
Okay.
until July.
Yeah.
All right, send me all of it. Data, names, whatever. We're fighting a war here. We need the whole country on board.
I think sometimes people don't present what an AOT is in the most effective way. Because even among my coworkers, when if we switch cases or something, I come in and I let people know AOT is not punitive. AOT is support. Somebody in your life, whether it was the hospital, a loved one, the police, whoever, somebody saw you needed more support than you're getting. And that is what I am here for, is to be your support person through your mental health journey. And that is how I present AOT. And I think I'm the only one in my department that does, because I always try to be strengths-based. And I will say, when I do that, clients respond in a completely different way. And they're like, oh, I didn't know that was the AOT was for. I thought I was in trouble. I'm like, no, you're not in trouble. You just need extra support right now. And that changes so many things for people.
Right. And it'll actually save them from getting in trouble.
Exactly, because we have mental health court, and I try to explain, I'm a step before mental health court. Let's keep you out of that. Let's keep you out of that program.
That's punitive, right?
Exactly.
Thank you for your help.
Well, we're coming to the end of the hour. Any last comments for the good of the order? I will just say I really appreciate you all joining and participating in this. These web chats happen monthly for the most part. Different professionals are called on every month. So we are hoping to add a new segment and have a peer supporters web chat in the new year. But look for a schedule in Shanti.
Hi, everyone. Coming right at the end.
Yeah, I was just gonna say. Look for a schedule of those early in the new year. Is that fair, Brooke?
Yes. Yeah, normally we're kind of switching our collaborator group. So we have this one for clinicians, we have the AOT monitors one, the AOT judges one, and then the champions one, which is kind of designed for our advocates, grassroots, family members, etc. And then we're adding the peers, but I don't think we're going to be on the same quarterly schedule with the peers added because we'll have too many groups. So we won't be meeting quite as often, but I would definitely encourage all of you too, that if you're looking for assistance with, a particular barrier, or you just want to talk something through, you can always reach out to our team outside of these chats. I will put you can email any of us directly if you have our direct emails, but I'll also put our team email in the chat, and please feel free to use it anytime. We're here to help.
And by the way, it's AOT at TAC. So it's
that's true. I put it in the chat, but it's not that complicated of an email.
AOT at TAC.org. So
I just want to announce as well that tonight we're having a live peer talk with Matt and Michael Stick. If you don't know who they are, from Tulsa, Oklahoma, they are a father and son. Matt is in his 30s. When he was 19, his onset of psychosis was so fast that he ended up with tragedy before his first psychiatric appointment. So he killed his mother, and his father fought very hard for him not to be punished with prison. And so he's been in 9 years of hospitalization, and he is he was released 2 months ago to the family. And they are going to be speaking tonight live with question and answer if you wanted to see it. NSSC website, National Shattering Silence. So it's nsscoalition.org, or you can see it on LinkedIn or Facebook or any platform. It'll be on YouTube. It'll live there forever afterwards, but the live portion is tonight, 7 p.m. Eastern, with question and answer.
Thank you, Laura. That is bound to be impactful.
Hopefully, people will come and listen.
Yep.
Thank you.
Well, thank you. And you all have a good holiday season. And we'll see you next time we see you.